As many as 5% of school-age children have a manifest strabismus, and many adults develop strabismus due to a variety of conditions. This videotape is an introduction to the basic ocular motility examination, which documents and quantitates strabismus, that is, ocular misalignment associated with either abnormalities in binocular vision or faulty neuromuscular control of ocular motility. The 6 rectus and oblique muscles control directional movements of the eye within the orbit. They are the medial, lateral, inferior, and superior rectus muscles, and the inferior and superior obliques. All muscles are innervated by cranial nerve number 3, the oculomotor nerve, with 2 exceptions. Innervation for the lateral rectus muscle is cranial nerve number 6, the abducens, and for the superior oblique, cranial nerve number 4, the trochlear. Both the lateral and medial rectus muscles have only horizontal action. The medial rectus is an adductor, and the lateral rectus is an abductor. Versions are binocular eye movements in the same direction. By evaluating versions in the 6 cardinal gaze positions, it's easy to observe asymmetries in the actions of a pair of yoke muscles, that is, to note underaction or overaction of a muscle when compared to its yoked partner. To test versions, have the patient look left, right, up and right, up and left, down and right, and finally down and left. It is also helpful to move an object in front of the patient to examine smooth pursuit movements. This patient's versions demonstrate overaction of the inferior oblique, which produces excessive elevation of the adducted eye. It also produces divergence in up gaze, known as a V pattern, which is secondary to the abducting action of the inferior oblique. These eyes exhibit excessive depression in adduction, which indicates an overaction of the superior oblique. When there is oblique overaction, it is frequently possible to see underaction of the antagonist, as shown here by these underacting inferior obliques. The divergence in down gaze, known as an A pattern, is secondary to the abducting action of the superior oblique.
The first thing I do in an ocular motility exam is make sure the patient is comfortable and relaxed, because it yields better information. I determine whether or not the patient is able to fixate, since most of the tests are dependent upon fixation. In the case of young children, I sit down immediately so as not to stand over the child. I raise the exam chair to make sure the child is at least at eye level with everyone in the room. Then I address the child directly, complimenting them on their clothing or asking them about school or vacation. Then I begin the exam immediately before taking any additional medical history so as not to lose their attention. Brightly colored toys, pictures, and barking dogs or movies also help to hold their attention.
Begin the exam by having the patient fixate on a distant target and read letters or describe objects. Evaluate head position during fixation by looking for anomalies such as chin up or down, a face turn, or head tilt. Note whether the fixation in each eye is central or eccentric, and if fixation is maintained with each eye. Note nystagmus if it is present. Is the fixation steady or unsteady? The next steps of the exam are based on information gathered by having the patient look in the 6 cardinal gaze positions. They are known as the cardinal positions because one muscle of each eye is the prime mover. The prime movers for each position are called yoke muscles, since they act in concert with each other. The cardinal positions and prime movers are as follows: eyes left, right medial rectus, and left lateral rectus. Eyes right, right lateral rectus, and left medial rectus. Eyes up and right, right superior rectus, and left inferior oblique. Eyes up and left, right inferior oblique, and left superior rectus. Eyes down and right, right inferior rectus and left superior oblique. Eyes down and left, right superior oblique and left inferior rectus.
An organized, step-by-step approach to the basic ocular motility examination can yield useful and accurate data even with uncooperative and very young patients. This will, in turn, allow more successful and earlier treatment to eliminate diplopia, promote normal binocular vision, and prevent or minimize amblyopia.